Hello, I'm Bobby Jean Schweitzer, and I am presenting on Endocrine and Metabolic Systems, Part 3. So this lecture will consist of modules on salt and water balance disorders and carcinoid syndrome. We'll start with salt and water balance disorders. And we'll start with a question. A 54-year-old male with metastatic lung cancer and recent pneumonia presents for a thoracotomy and wedge resection. His preoperative serum sodium is 128. All of the following are possible diagnoses except A. Cerebral salt wasting, B. Syndrome of inappropriate antidiuretic hormone, or SIADH, C. Hypothyroidism, or D. Diabetes insipidus. The answer is diabetes insipidus. So answer D is correct because hypernatremia, not hyponatremia, occurs with diabetes insipidus. Answer A is incorrect because cerebral salt wasting could be a result of brain metastases, and hyponatremia is present in cerebral salt wasting. Answer B is incorrect because SIADH is associated with carcinoma of the lung, and hyponatremia is present in SIADH. And answer C is incorrect because hyponatremia can be present with hypothyroidism, and this patient could have hypothyroidism for a variety of reasons, including its common occurrence after head, neck, or chest irradiation. So water balance is primarily controlled by thirst mechanisms. There's osmoreceptors in the hypothalamus, which control our thirst. There's low pressure receptors in the right atrium and the great veins, which respond to volume status. And there's high pressure baroreceptors in the carotid sinus, which respond to volume status. Antidiuretic hormone, or ADH, is the primary driver of fluid and volume balance. ADH increases free water reabsorption, and it also increases urine concentration. The stimulus for ADH secretion includes increased extracellular tonicity and hypovolemia. Sodium balance is controlled via renal excretion. Sodium reabsorption occurs in the proximal tubule. Atrial natriuretic peptide, or ANP, causes natriuresis, or sodium excretion. It has the opposite effect of aldosterone. Beta, or brain natriuretic peptide, is similar to ANP. So sodium is defined as normal, or hyponatremia, or hypernatremia. Normal is considered a sodium of 135 to 145. Hyponatremia is when a sodium is less than 135, and hypernatremia is when sodium is greater than 145. Both extremes have profound effects on the central nervous system and cellular homeostasis. Both conditions are typically classified as either being mild, moderate, or severe. The symptoms associated with moderate hyponatremia include lethargy, nausea and vomiting, irritability, headaches, muscle weakness, or cramps. Severe hyponatremia is associated with drowsiness and confusion, depressed reflexes, seizures, coma, and even death. Hypernatremia when moderate, has associated symptoms of lethargy, thirst, and irritability. When more severe, hyperreflexia, ataxia, seizures, and coma occur. So this is an algorithm for defining and including a differential for the causes of hyponatremia. Again, hyponatremia is defined as a sodium of less than 135 millimoles per liter. First, one should assess the osmolality, and if low, then one assesses urine osmolality. If the urine osmolality is less than 20 millimoles per liter, one should consider extrarenal sodium losses and edematous states. If the urine osmolality is greater than 20 millimoles per liter, then one assesses the volume status. If hypovolemia is present, one considers cerebral salt wasting syndromes, mineralocorticoid deficiencies, and renal sodium losses. If one is hypervolemic or euvolemic, one considers SIADH, glucocorticoid deficiency, or hypothyroidism as etiologies. If one's serum osmolality is normal with hyponatremia, then one should consider pseudo-hyponatremia or hyperlipidemia. If one's serum osmolality is high with a low serum sodium, then one should consider hyperglycemia and the administration of mannitol as etiologies. This is an algorithm for the evaluation of hypernatremia. Again, hypernatremia is defined as a serum sodium of greater than 145 millimoles per liter. First one assesses the urine osmolality, again, similar to hyponatremia. If one has a urine that's inappropriately dilute or a very low osmolality, then one should assess the volume status. If the volume status is hypovolemic, then one considers diabetes insipidus or renal disease as etiologies. If the volume status is eu or hypervolemic, then one should consider mineralocorticoid excess. So if you have hypernatremia and your urine osmolality is elevated or appropriately concentrated, then one assesses volume status. If your volume status is euvolemic or hypervolemic, then one considers iatrogenic sodium administration as the cause. If the patient is hypovolemic, then extrarenal water loss is typically the cause. So this contrasts the various findings in various conditions that are associated with hyponatremia. So you can see across the top there, I've divided into SIADH, cerebral salt wasting syndrome, or diabetes insipidus. All of these are diagnoses that can cause hyponatremia, and one can differentiate them by looking at various things such as the plasma volume, the sodium balance, the water balance, the serum sodium, the serum osmolality, the urine sodium, and the urine osmolality. So across the way there, you can see that with assessing the plasma volume, it is typically raised with SIADH, but lowered with both cerebral salt wasting and diabetes insipidus. Looking at sodium balance, the second line, in SIADH, sodium balance is usually elevated or normal, and with salt wasting syndrome or diabetes insipidus, there's a negative or normal sodium balance. Water balance is positive with SIADH and negative with both salt wasting and diabetes insipidus. Serum sodium is low in SIADH and cerebral salt wasting syndrome, but high in diabetes insipidus. Serum osmolality is lowered, typically in SIADH, can be either high or normal with salt wasting syndrome, and is typically high with diabetes insipidus. The urine sodium is high in both SIADH and cerebral salt wasting syndrome, but normal in diabetes insipidus. And the urine osmolality is typically high in SIADH, normal to high in salt wasting syndrome, and low with diabetes insipidus. Just to help you define, normal values of plasma osmolality is 278 to 305. Normal values of plasma sodium is 135 to 145. And normal values of urine osmolality is 350 to 1,000. And urine sodium is 20 to 60. So let's talk a little bit more in depth about SIADH. The diagnostic criteria for this is a serum sodium of less than 135 millimoles per liter or delusional hyponatremia. The serum osm is less than 280 millimoles per kilogram. The urine sodium is greater than 18 millimoles per liter, and the urine osm is greater than the serum osm. One also needs to have normal thyroid, normal adrenal, and normal renal function. One can be either euvolemic or hypervolemic, and one can have either decreased or normal urine output in SIADH. So SIADH is associated with neoplasms, particularly pulmonary neoplasms, but also benign pulmonary disease, infections, medications, and central nervous system disorders. The management is typically free water restriction to 1 liter or less per day. Dimethylcycline can be used. It's an antibiotic and an ADH antagonist. Furosemide can also be used to help cause a diuresis of free water, and supplemental sodium chloride can be used in severe cases or in patients who are hypovolemic with SIADH. So cerebral salt wasting syndrome is a condition that's associated with dehydration and low total body sodium. It is caused by an increase in sodium excretion or wasting of sodium, and increased urinary sodium levels. It's usually secondary to brain tumor, trauma, or brain injuries. The patients typically have a large amount of urination and excessive thirst. The management is usually treatment of the underlying condition with spontaneous resolution, though one can replace fluid with 0.9% sodium chloride. Fludrocortisone can increase sodium reabsorption as well. Diabetes insipidus is the inability to concentrate urine. There's hypernatremia with a sodium level typically of greater than 145 milliosmoles per liter. There's a high plasma osmolality associated, greater than 300 milliosmoles per liter. Low urine osmolality. If you have central diabetes insipidus, then the urine osmolality is typically less than 200 to 300 milliosmoles per liter. If there's a nephrogenic diabetes insipidus, then the urine osmos is usually 200 to 500. Diabetes insipidus is associated with dehydration, polyuria or excessive urination, and polydipsia or excessive thirst and drinking. There's 2 main mechanisms of diabetes insipidus, either central, which is due to an inadequate antidiuretic hormone secretion, or nephrogenic, which is due to insensitivity of the distal nephrons of the kidneys to antidiuretic hormone action. The differential includes solute diuresis from hyperglycemia, dehydration, pre-admission volume resuscitation, mannitol administration, or hypertonic saline therapies. So DI etiology, again, can be divided into either a central or nephrogenic DI. Causes of central DI include anoxic encephalopathy, hypophysectomy or pituitary resection, brain surgery, traumatic brain injury, brain death, brain tumors, hemorrhage, and infarctions of the brain, meningitis, and encephalitis. Nephrogenic DI is related to, again, the insensitivity of the kidney to ADH, and this can occur secondary to medications such as amphotericin, dobutamine, lithium, contrast dye, aminoglycosides, or vinblastine. Hypokalemia and hypocalcemia can also cause a nephrogenic DI, or associated with nephrogenic DI. There's a polyuric phase of ATN, interstitial renal disease such as sickle cell disease and polycystic kidney disease can all cause nephrogenic DI. So what is the management of diabetes insipidus? Well, you first need to calculate and replace the free water deficit. This can be done by taking the patient's weight in kilograms and multiplying by 0.6, then multiplying the patient's sodium minus the desired sodium divided by the desired sodium. You should not correct sodium too fast. It should never be corrected faster than 0.5 milliequivalents per hour, and this is to avoid causing cerebral edema. One typically replaces half of the deficit in the first 24 hours and the rest over the next 24 to 48 hours. With central DI, that can be treated with vasopressin, 2 to 5 units subcutaneously every 4 to 6 hours to replace the absence of antidiuretic hormone, or using desmopressin, better also known as DDAVP, which is given in 2 to 4 microgram per day doses subcutaneously, typically twice a day, or it can be also administered intranasally as a spray. Nephrogenic DI, one needs to correct the underlying condition, so withdrawal of medications or correcting the electrolyte disturbances or the other disease states to correct DI. Let's talk a little bit about carcinoid syndrome next. So carcinoid syndrome is the excessive secretion of serotonin and other hormones, often from neuroendocrine cells, which can occur anywhere in the body. The most common causes of carcinoid syndromes are tumors from organs derived from the primitive gut. About 90% of these occur in the distal ileum or the appendix. Appendiceal carcinomas are the most common. Ileocarcinomas are commonly metastasized to the liver. So carcinoid syndrome presents with the classic symptoms of flushing, diarrhea, wheezing, cardiac murmurs, hypotension, and dizziness. The hypotension is in stark contrast to the hypertension seen with pheochromocytomas. So what is the diagnosis and treatment? Well, the diagnostic screening test is measuring urinary 5-HIAA, which is hydroxyindole acetic acid. If levels are greater than 25 milligrams per day, and also, this is a metabolite of serotonin. The confirmatory test is usually an octreotide scan. It's similar to the scan I showed you for the diagnosis of pheochromocytomas. So the treatment is octreotide, typically treats the symptoms. One should avoid sympathomimetics, and one should maintain an appropriate depth of anesthesia when caring for patients who have carcinoid syndrome. Thank you very much for your time.